Our last speaker for this afternoon is Dr. Sian Griffin, who is a consultant nephrologist and honorary professor of nephrology in Cardiff. Her subspecialty interests include immune-mediated kidney disease, transplantation, clinical trials, and holistic care, including reproductive goals for patients with chronic kidney disease. And she's here to talk about lupus and the kidney and advances in treatment. Thank you ever so much.
Lovely, thanks very much. And thank you very much for the invitation to join you this afternoon. I feel very lucky going after our first two expert speakers who've really set the scene broadly about lupus from their background in rheumatology. I'm going to stay very much in my lane and talk about lupus and the kidney and defer to my colleagues for their broader knowledge of lupus. So lupus is a condition that affects both humans and mice, and we've learned a lot from mice, and they continue to teach us a lot about the genetics and the consequences of some of the changes that we've recently recognised in humans with lupus. It's an autoimmune disease, so as we've heard, this is a condition when your immune system, which is designed to deal with infections, actually attacks your own tissues. And we're aware that there's a very strong genetic predisposition for this. So it's not a case of having a single genetic change that causes disease. We know that there are about 100 genetic variants that will increase your susceptibility of developing lupus. And these will then interact with your environment, with your exposure as an individual to different infections, and it will result in the specific manifestation of lupus that you might get. So the genetic predisposition is very important, but then there are lots of other factors that come into play which determine how lupus may actually play out for an individual. We've heard from Dr. Call about the high prevalence of anti-nuclear antibodies in the general population. And what seems to happen in patients with lupus is that a trigger will come along that will expose the nuclear contents of the cell, and the antibodies they have will bind to those cells, forming what's called immune complexes. And then these are in the circulation, and they gum up the tiny blood vessels and cause inflammation. And so the areas of the body that are often affected are the kidney, where you have these very small blood vessels, and then also in the lining of the abdomen, the lining of the lungs, in the heart, in the back of the eye, in the small vessels around the joints. So these immune complexes will stick up the blood vessels, and then you have inflammation around it. This is a picture of Selena Gomez, who's an actress with lupus, who's had 2 kidney transplants now, and she speaks very honestly about her experience, and she's reflected on her neuropsychiatric manifestations and how difficult that has been for her, and she's a great advocate for the disease and its management. The condition is more prevalent in people with a black, Hispanic or Far Eastern origin. And interestingly, the strains of mice that are more likely to develop lupus all come from those parts of the world. And it seems to be that it's because having this immune system that's very revved up, that's very hyperreactive, protects you against some of the infections that are endemic in those areas, particularly malaria. And so the evolutionary advantage of people with lupus was to protect against infections, but the consequence of that has been increased susceptibility to autoimmunity, which is what we now see as the problem. And so if you have involvement of the kidney, that's what we call lupus nephritis, and nephritis is inflammation in the kidney. And many people with this have no specific symptoms, which is why urine testing is so important. So the urine dipstick test shows the presence of blood and protein, and is very, very valuable in lupus, both at the beginning and also for monitoring. And it really should be done every time you go to clinic. I'm in a kidney clinic, so we're very well set up for that, but I'm conscious that in other clinics where other problems predominate, it's not the priority of people running those clinics, but it's a very simple test to do. If there's a lot of protein in the urine, then the protein level in the blood falls, and fluid isn't retained in the circulation and leaks out into the tissues, and so people develop ankle swelling, facial swelling, and the urine can actually look very frothy. If the involvement is very severe and kidney function falls very rapidly, then patients may notice they're passing less urine than usual. And then when we meet people, the blood pressure is often very high. The kidney is central to control of blood pressure, and if there's low kidney function, the response is to elevate the blood pressure. Urine dipstick, as I've mentioned, and a blood test, as we heard, will show the abnormal kidney function. And then the consideration is whether a kidney biopsy is necessary. If the involvement of the kidney with lupus is mild, the mainstay of treatment is mycophenolate, and it may often be if there's more serious involvement. So if we see a patient whose kidney function is normal, whose blood pressure is normal, and there's a small amount of blood and protein in the urine, we wouldn't usually proceed to a kidney biopsy because the treatment would be the same. But if there are any concerns about any of these parameters, we would. It's useful not only for diagnosis but also for prognosis in terms of what we see when we do the biopsy. So this is where your kidneys are. They're tucked under the rib cage at the back, and you can have conditions that affect one kidney, such as cancer. But for conditions like lupus, both are affected. They're part of the circulation, and they will both be affected if one is. And this is how we would do a biopsy into the lower part of the kidney. And then these are quite detailed slides, but I thought it'd be helpful to understand what's going on in the kidney. And so the large cartoon shows that the blood goes in, and then the blood vessels branch and become ever smaller as they go towards the outside of the kidney. And they then form into these little knots of blood vessels, which are shown in the cartoon up there. And this is called a glomerulus, which is just a wonderful word. And the reason it does this is to produce a very, very large surface area for the production of urine. And so the blood flows through these tiny vessels, and fluid from the circulation leaves, and this is the primary urine. And then the blood vessels then gather back up together again to form a large vessel that then leaves the kidney. The picture on the top left is a scanning electron micrograph of what these little balls of capillaries or glomeruli look like. And really illustrating this extremely large surface area that the kidney has. And then when we look at it under the microscope, we are looking at a cross-section through that glomerulus to see what sort of involvement there is. And in a normal kidney, there's quite a lot of cells there, but you can see the blood vessels are nicely open, and there's a space around it that the urine's formed into. But in lupus and other conditions causing inflammation, there's swelling, so the glomerulus looks large. There are lots of extra cells that have gone in to contribute to the inflammation, and there's a lot of production of what's called extracellular matrix, which is very scarring in the kidney. And you've lost that nice little space that the urine is produced into. And so there's a lot of inflammation going on, and the site of it is these very small filtering units. So the treatment of lupus, from my perspective, is immunosuppression, drugs to control the immune response that's resulting in the damage to tissues, to protect the kidney and also the heart and blood vessels, because these are all very closely linked in what you have heard referred to as your cardiovascular health, and then supportive care for all the other medical consequences of having kidney disease. And I completely agree with Chris that the fourth item on this list should be psychosocial support. It's a lifelong condition, it's unpredictable, there are periods of exacerbation, periods of remission, and it has implications for many aspects of life. And I totally agree we should have psychological, social issues on this list. And so the immunosuppression, the balance has always been to control lupus activity, prevent relapse and avoid kidney damage. But the challenge is to ensure we get the balance right with the maximum effect to control lupus, but not exposing people to adverse side effects and toxicity. And if we go back 50 years or so, the drugs we had available for lupus were steroids, which were often used in very high doses, and cyclophosphamide, which was originally used for chemotherapy. was then found to be helpful for these aggressive autoimmune conditions. And we used very high doses, and it would control the disease, but at the cost of really very severe side effects for the patient. So our approach now is undoubtedly much more nuanced, to get that balance right between disease control and minimal side effects. So the initial immunosuppression for most people at the moment, if there is significant lupus, and one of the indicators of significance for the kidney involvement are steroids, and we're using much lower doses than previously, and we aim to reduce and withdraw them over a few months. In the past, these would have been continued for years, and I look after many people at the moment who have been on steroids for very many years, and it's then very difficult to withdraw them because your own steroids production will have been suppressed by that long-term treatment. So although I aim with my new patients to get them off steroids, I will look after many people who are on a small dose. Hydroxychloroquine is a very well recognised drug for controlling lupus activity. The mechanism of action is not completely clear, but it has a role in controlling the activity of the cells that are overactive in lupus. And then mycophenolate mofetil is used very frequently to control the disease. It's not without its side effects, principally nausea and diarrhea, which often limit getting up to the full dose and limits its use. And we do still use cyclophosphamide, which I mentioned previously, but at a very much lower dose now, which has been shown in trials to be as effective as the very high doses we used previously. And we would use these three drugs in combination. So rather than having an enormously high dose of steroids, we now have these other agents that enable us to use a sensible dose of 3 drugs rather than only treating with one. And until very recently, when some new drugs became available, we did have a couple of other things up our sleeves if needed. So rituximab, which again reduces the cells that are causing inflammation if the original treatment wasn't sufficient, and a drug called tacrolimus, which is used in transplantation, is very helpful if the kidneys are weak in order to protein. So then to protect the kidney, heart and blood vessels, again there have been some new developments in this area. Patients with lupus are vulnerable to cardiovascular problems, not only as a consequence of the kidney involvement and high blood pressure, but also the inflammation more generally that's associated with lupus. And so control of blood pressure is important to control the decline in kidney function. We have agents that are used to treat blood pressure, ACE inhibitors, that are also very good at protecting kidney function. And a drug that was developed for the treatment of diabetes that has also been shown to protect kidney function. We're now prescribing that for most of our patients with falling kidney function. As your kidney function reduces, there are a number of knock-on complications from that need to be treated. And ultimately, some patients will need to consider transplant or dialysis if their kidney function falls to the point at which it's not able to, you're not able to rely on that to keep you alive. And diabetes may accompany lupus, particularly if there's been prolonged treatment with high-dose steroids. And again, this is a condition that affects the kidneys, and it's important that our treatment of that is very, very good. So just thinking about supportive measures, which are very important, and Sally Hopkins is another actress with lupus, who again has been very open about her experiences. I think this is helpful. I think when a well-known person is comfortable to say, I have had this disease, this is how it's affected me, I think it raises awareness in the general population, and perhaps also for patients that we're not alone. There are other people with the condition. So diet is very important, and the Mediterranean diet, with its emphasis on plants, vegetables, fish, olive oil, avoidance of dairy products, avoidance of red meat. Low salt is very important because this can drive the rise in blood pressure. Smoking cessation is important for many reasons, one of which is the irritation it can cause to blood vessels. So both for patients with kidney disease generally and also lupus specifically, smoking cessation is very important, and there are measures available through the NHS to help you if you're finding that difficult. And then exercise is also important, and it's really whichever exercise is going to suit you and you're going to be able to continue with. So a combination both of strength building and also cardiovascular, but really whichever one you like, so that together with your diet you can maintain a healthy weight. And then thinking of the other knock-on effects of treatment and kidney disease, you may need treatment to prevent osteoporosis. Patients can be susceptible to infection, so vaccinations are important. Sunblock and adherence to treatment is a really tricky one, particularly for young adults, teenagers coming up through the children's service. And there are many factors that lead into poor adherence with drug regimens. And again, there are many measures available to help remind people to take tablets. So information as to what they're needed for, reminders on phones, that sort of thing, but adherence can be a big issue. And then pregnancy is also a very important consideration, and that's something I do talk to people about quite a lot. Lupus is typically a condition that affects young women, and pregnancy is something that needs to be thought about quite carefully, and to make sure that the treatment is correct for pregnancy, and then also to ensure appropriate monitoring during the course of it. So a little bit about development of new drugs, because we've heard already about a couple of the new things that have come through, which is very exciting. It takes a little while for new drugs to come through to market. At the beginning, there'll be a lot of scientific research. There may be studies in animals. There will be phase 1 studies, which are the use of the new agent in the normal population. And then that builds up to clinical trials. And these are conducted extremely carefully. The entry criteria are usually extremely specific in terms of your characteristics, and there are usually a lot of exclusions. So the drugs are trialled in a very specific patient population. But then if they're successful, they're put forward for marketing authorization and then licensing for a specific indication. And in the UK, that's handled by the Medicines and Healthcare Regulatory Authority. The reason the market authorization and licensing are important is that there are a lot of drugs that are in use for other conditions that we repurpose for the use in lupus. So mycophenolate tacrolimus were not licensed for lupus, they're licensed for other conditions, but we have been able to use them because they're authorized. And what I think is exciting about the recent developments in lupus is these were drugs specifically for lupus. We haven't had to pinch a drug from somebody else. They're things that we were for patients with lupus. So you may find you have a discussion with your consultant at some point when perhaps you've had side effects with a number of different agents and they're looking at something else. And there may be drugs available that are authorised, they're safe, they're available for clinical use, but they're not licensed for lupus. And often in those situations, we as clinicians need to go through a couple of other hoops to ensure we get approval and funding in place for you to receive those drugs. So authorisation and licensing are slightly different. So when the clinical trial is complete, there's then an evidence appraisal, so that recommendations are made to the clinical community, so that these drugs are rolled out and are used more widely. And in the UK, that's provided by NICE, the National Institute for Health and Care Excellence, which Paul referenced earlier when talking about the Doppler score and approval. So despite a clinical trial, we generally can't use a drug until NICE have approved it. And so they will do the evidence appraisal, not only of the clinical trial, but of any other publications that have come through using those drugs. And then at the same time, clinical societies will make recommendations in their guidelines. And for me, the guideline that's most closely followed is a global guideline for kidney disease. And the recommendations for lupus were made in 2020. But so much has changed in the last 2 years that these are actually being rewritten at the moment. And they're usually rewritten every 5 to 10 years. So the fact that they've had to revisit them 2 to 3 years after publication really shows what an exciting time we're in. And then there's implementation. So once NICE have approved a drug, in Wales, the Welsh Healthcare Specialist Services have to approve it within 60 days and make it available for use. So that probably sounds frustratingly long, but that's actually quite quick for them to have reviewed the evidence, agreed for it to be used, for it to go to the health board to put it on formulary, for me to be able to write a prescription. So there's a very careful process that drugs need to go through before they're delivered to you. But there are a few things that have come through. And what's interesting about the trials of these drugs is these were all tested as add-ons to current standard of care. So everybody who went into the trial was on steroids, mycophenolate and hydroxychloroquine, and then this was added on to their treatment regimen. So the results of the trial are compared to what is standard of care. So we don't have trials of somebody presenting a new presentation, having this as their first line treatment. It's as an addition to what we're already doing. And there's a precedent for that in drug development, particularly in the cancer field, where any new developments are compared to what is our current best practice, rather than as something that's completely new. So belimumab has been available for a few years now for general lupus, and more recently we have the evidence to use it for lupus nephritis. So that's very good. The voclosporin NICE approval came through just over a week ago. And I think this is a good example of the specificity of the patient population that we used in the trial. So although it's for lupus nephritis, although it's for kidney involvement, one of the inclusion criteria was that you actually had quite good kidney function. And that's because one of the side effects is to cause a constriction of those tiny little blood vessels, which can drop your kidney function. And if your kidney function is already low, you're more vulnerable to that. So to receive voclosporin, you have to have quite good kidney function. And then if you look at the complete response rate at the end of the year, the response with voclosporin was about 40% compared to about 25% with standard care. So although it is better, it's not fantastic, it's not 100%, and I think a 40% complete response rate, I think we can still do better. And then obinutuzumab, again, that Paul mentioned, is more effective. It's a higher affinity form of rituximab, and so because of that higher affinity of binding to its target, it's likely to be more effective. And this is important because it's used in a number of hematological malignancies. So it's gone through its marketing authorization. We know it's safe to use, but it's not licensed for lupus. But it is available as an alternative if somebody has had an allergic reaction to rituximab and can't receive retreatment. We could apply for funding to use obinutuzumab. So although not yet licensed, it is another useful agent for us. And then anifrolumab works in a completely different way. It works to inhibit interferon, which is a molecule in the circulation that drives inflammation. And it tends to be increased at the time of infection, so that your immune system is revved up a little bit to deal with those infections. And so for patients with lupus, interferon tends to be very active as part of this autoimmune process. So anifrolumab is effective for lupus, and it's approved in the States and in Europe, but the company didn't make an application to NICE, so they haven't been able to review the evidence for its use. So anifrolumab is not yet licensed in the UK. So what's coming next? The way I see these new drugs at the moment is that we will probably start treatment with standard care, and that will work very well for some people. It will work fairly well for some people, and it won't work at all for others. And at the moment, we don't know which group people are going to fall into when we start treatment. So I think what's going to come through in the next few years is personalisation of treatment, and that's going to be driven by why has the individual patient developed lupus. And there have been a lot of very exciting developments in basic science that are now being applied to clinical science that allows us to look much more closely at the genes of an individual and what's happening with their immune system, so that we can say it's happened to you because this has changed and that's what we're treating, rather than treating the end result of lupus, which may arise from many different upstream abnormalities. And I think that's going to be the direction of travel. I think we're going to have some novel drug targets, and again, the very rapid advances in genetic sequencing and immune cell analysis are going to drive this. And so there was recently a very nice paper from Spain that talked about a child who developed severe lupus, and she had a gene mutation that in itself was enough to cause disease. And it's a protein that's involved in the immune response to viruses. It's one of the targets of hydroxychloroquine. The genetic mutation was put into mice. The mice also developed lupus, and it's what's called a druggable target. So it's a molecule to which we can develop treatments, and those are now starting to come through into clinical trials. And I think that's really exciting. I think in the future we'll be looking at things much more differently. We'll be much more sophisticated about defining what it is about you that has caused the development of lupus. And then the final thing that I'm also very interested in at the moment are cell therapies. So when you've had inflammation in a tissue, the inflammation subsides and then it either resolves or there is scarring. And we know a lot more about the different cells that drive the tissues in either direction. And there are now studies coming through where we will infuse cells into the individual that will help deal with the scarring, give some remodelling and allow repair rather than scarring, which is irreversible and causes progressive damage. So there's quite a lot on the horizon, and I think the future is really going to be a very exciting time for lupus. I think there's going to be a lot coming through in the next few years. So happy to answer any questions with my colleagues. Thank you.
Thank you very much, Dan.